Oh, dear God. Let's see if I can. Believe it or not, we actually just practiced this. Oh, for the love of God.
Always works better in rehearsal, Carlos.
It really does. And I mean, that's what I've heard about the whole family dinner and all that, right? Well, so I'll tell you guys what. Oh, dear God. I wanted it to get. So, many of you are familiar with the whole New England Surgical Society tradition of scholarly work and collegial um, collaboration, if you will. And our effort with this has been to really provide a resurgence in the whole concept of what we all remember as residence journal clubs. And, I think there's no better place than in the whole New England region. Tonight, we're really fortunate. This is another one of our New England Surgical Society intellectual happy hour installments. And we're going to be discussing, something that I think is revolutionary, something that one of our dear friends here of Vermont has been a big part of. Many of you will remember that the total mesorectal excision, or TME, was probably one of the most important events in surgery in the management of rectal cancer. TME, as it was originally proposed and described by Dr. Heald, reduced the local recurrence rates and extended the 5-year survival. Now, I shamefully will admit that when I was a resident at Georgetown, and many of you know that Georgetown is a good Jesuit institution, the Holy Plain, as it was described, I felt was something that was being sort of lauded because of our Catholic institution, only to be later corrected by many of my attendings that it was actually proposed by Dr. Heald from England. Again, the TME was a critical component to the standard management of rectal cancer. But we have evolved and we continue to evolve, thank God, as you'll see. And tonight we're very fortunate. We've got Dr. Tess Aulet, one of the assistant professors at the University of Massachusetts Memorial Hospital, will be presenting what I think is a landmark paper and has really sort of pushed a paradigm shift on organ preservation in patients with rectal adenocarcinoma treated with total neoadjuvant therapy. We will also have Dr. Jason Hall, who is a surgeon in chief and chair at the Department of Surgery at Tufts Medical Center, as one of our senior discussants. And there are many of you who I know are big fans of The Masked Singer. And so, in the interest of, where life imitates art, we actually have our own masked surgeon who will come in at the very end and provide some closing comments. At this point, I'd like to turn it over to Dr. Tess Aulet, who will lead the discussion and presentation. Thank you very much for participating with us tonight, Dr. Aulet.
Thank you. Happy to be here. Can everybody hear me okay? All right, awesome. So it's really awesome to be able to present this article. I trained at University of Vermont for residency, where we were a major accruer of patients for this trial. And so it was really exciting to be a part of that as a resident, hearing about it in tumor board discussions, seeing it in the clinic, and then recently seeing the results published and now being able to discuss them. So I'm going to just share my screen. All right. Okay. Everybody see my slides okay? Perfect. Thank you. All right. So I'm going to be talking today about the OPERA trial. The purpose of this trial, and I'm going to jump a little bit next into some background as to how we got here. But this was a prospective study looking to investigate the efficacy of watch and wait strategy in order to achieve organ preservation in patients with locally advanced rectal cancer treated with total neoadjuvant therapy. And why do we care about this? The rectum, as an early resident, I would always hear the term LAR, low anterior resection syndrome, and kind of understand a laundry list of symptoms, clustering, frequency, urgency, but it didn't really click until I kind of thought a little bit more about, how high fidelity the rectum is and what really happens surgically when we remove it. So if we think about the pathophysiology of the rectum and what it does, it's a pretty high fidelity organ. It allows, has different nerve innervation, different muscle compared to the colon. And so when we think about taking the colon, not the smartest organ, removing the rectum and connecting the two, we can really impact and change people's quality of life and their function. And so I think, thinking about that and why this study and how our evolution of treatment of rectal cancer has evolved is really important. So how did we get here? I could spend 2 hours just talking about this, so I'll try to be brief, but originally, as Dr. Marroquin alluded to, is, patients with rectal cancer were treated with surgery alone before they were routinely treated with chemo and radiation. That left us with high rates of local regional recurrence. And so then we began adding in, sorry, my slides aren't advancing. Oh, sorry. So then we started adding in chemotherapy and radiation therapy. And oftentimes this was done adjuvantly after surgery. And now we've kind of started to shift that to upfront treatment. And that came about really, I think, with the Swedish and Dutch trials in terms of establishing the use of preoperative radiation. The Swedish trial compared surgery alone to pre-op radiotherapy, demonstrating that there was decreased local recurrence and improved overall survival with the use of preoperative short-course radiotherapy. And the one thing that differentiates the Swedish trial from the Dutch trial is they did not focus on surgical technique. The Dutch trial looked at preoperative short-course radiation therapy, followed by TME versus TME alone. And so, the take-home points in the Dutch trial is that local recurrence in the pre-op radiotherapy group was decreased. And the Dutch trial showed us that radiation decreases local recurrence for locally advanced rectal cancer, but does not improve overall survival when we think about adding in a good TME resection. And so TME, as Dr. Marroquin talked about, was popularized by Dr. Heald, and it refers to the surgical technique that's the gold standard for rectal cancer dissection and surgery. This uses sharp dissection to fully excise the rectum and the mesorectum along the avascular plane, taking out outside of the rectal fascia propria and fully removing the rectum intact. So we want a good TME excision with the mesorectum intact. So then we kind of get to the German trial. The German trial looked at preoperative versus postoperative chemoradiotherapy. And this study showed us that pre-op chemotherapy had lower local recurrence, better compliance, less toxicity, and better sphincter salvage. And this study, I think, solidified the use of preoperative chemoradiotherapy. We also had the Polish trial looking at short course versus long course chemoradiotherapy. This showed us that long course had better downstaging, improved circumferential resection margin for our TME, but overall no differences in survival, local recurrence, and postoperative complications. So really for the most of the early 2000s, we treated patients with long course chemoradiotherapy surgery, and then patients got postoperative adjuvant chemotherapy as indicated based on their pathology. And then in comes Dr. Habergama in 2004, and the concept of total neoadjuvant therapy and watch and wait came about. So she published this paper in Annals of Surgery in 2004 on the non-operative management of rectal cancer following chemoradiation. And this was quite a radical concept at the time. The idea that preoperative therapy may lead to complete clinical response and that patients could actually save their rectum was huge. Her initial results demonstrated that in patients with a complete clinical response to chemoradiotherapy, there was no difference between surgery and observation in regards to recurrence as well as mortality. So then we get to this idea of TNT, or total neoadjuvant treatment, in which patients now get all of their treatment up front before surgery, with the proposed benefits being better compliance, better micrometastatic disease control, better downstaging, and also may allow for this watch and wait protocol. There's a lot of different papers on TNT, which I'm not going to go into. So again, just a shout out to Dr. Habergama, who was recently awarded in Boston for all of her work. So back to the OPERA trial. So they hypothesized that patients with locally advanced rectal cancer, stage 2 and 3, treated with TNT followed by either TME or a selective watch and wait approach based on the tumor response will have better disease-free survival compared to historical disease-free survival in those getting chemoradiotherapy. This is a prospective randomized non-blinded trial. There were 18 US institutions that participated. Patients who were included were locally advanced, either stage 2 or stage 3 rectal cancer. These had to be biopsy proven. They had to have a full endoscopic assessment, and then were imaged with MRI as well as CT, chest, abdomen, pelvis. Patients were excluded if they had recurrent rectal cancer, distant metastatic disease at the time of diagnosis, or a history of pelvic radiation. Patients were then randomized and treated with TNT, and this could be either induction chemotherapy followed by chemoradiotherapy or chemoradiotherapy followed by consolidation chemotherapy. Patients then had a TME or upfront surgery, or they were offered watch and wait approach based on their tumor response. Just to kind of fill in terms of the TNT regimens, these were standardized. Both groups had 4 months of either fluorouracil, leucovorin, oxaliplatin, or Capox, and then they received standard doses of radiotherapy. And then with the radiotherapy, got either fluorouracil or capecitabine during the radiotherapy for sensitization. In terms of assessing how the tumor responded, this was done endoscopically as well as with MRI. They were graded as either a complete clinical response, a near complete response, or an incomplete response. Any patient who had an incomplete response underwent a TME, and then complete or near complete were offered watch and wait. The watch and wait protocol kind of outlined here. So patients had a DRE and FlexSig every 4 months for the first 2 years, and then this was spaced out eventually to 6 months for 3. They had an MRI every 6 months for 2 years and annually for 3. If the tumor was found to regrow or had a non-sustained response, then a TME was recommended. And then TME patients who had surgery underwent their routine surveillance per the national guidelines. I think this diagram that's included in the paper is a nice schematic in terms of just outlining what I kind of just verbalized. But you can see here patients were randomly assigned to either, again, induction chemotherapy or consolidation chemotherapy. They were then restaged, and then they ultimately ended up undergoing either the watch and wait or the surgery. And you can see some periods of rest and just kind of the time to completion. So, you know, from the time to enrollment, 0 weeks, to the time of, you know, 36 weeks, around the time of when they're completing all of their upfront TNT. So really kind of changing the paradigm of how patients go through and experience treatment for rectal cancer. The primary endpoint that they looked at was disease-free survival. Secondary endpoint was TME-free survival. In total, they had 324 patients. This was over the period of 6 years. 158 of them had induction chemotherapy, chemoradiotherapy, while 166 had consolidation treatment, and the median follow-up was 3 years. You can see here, in general, the baseline demographics and characteristics were pretty equal across both groups. There was slightly more male predominance. A majority of the tumors were T3 in terms of the split of the tumor classification, and then the distance from the anal verge was tracked, and a lot of these were low tumors, at the average around 4 centimeters, and no difference between the two groups. In total, patients undergoing the TNT, there were 6 patients who died. 1 death was unrelated, but there were 5 deaths thought to be due to treatment of the TNT. There were no differences in rates of adverse event between TNT groups. 3-year disease-free survival for both induction and consolidation TNT groups was 76%, so no difference. The 3-year TME survival, however, there was a difference between the two groups. There was 41% in the induction chemoradiotherapy group, and then 53% in the consolidation. So patients who underwent upfront chemoradiotherapy had a higher rate of TME-free survival. There was no differences noted in local recurrence-free survival, distant metastatic-free survival, or overall survival between the groups. And that's, again, kind of demonstrated here in their Kaplan-Meier curves, looking at the local recurrence-free survival, disease-free survival, and distant metastatic survival. You can see no real difference. The other thing that they looked at was, again, TME-free survival, and you can see in the patients who underwent or started with chemoradiotherapy had a better chance of saving the rectum. 26% of patients were initially offered TME after TNT. 74% were offered watch and wait. Of these, 40% had regrowth in the induction chemotherapy, and 27% in the consolidation chemotherapy had regrowth. 60% of patients preserved the rectum in the chemoradiotherapy upfront with consolidation chemotherapy, and then 47% of patients preserved their rectum when they underwent chemotherapy first. In total, patients who ultimately had a TME, 10% of these, when they looked at the pathology specimen, had a complete pathologic response. So, you know, I think some of the things to think about in terms of this, digesting this article, in thinking about how to design and how we would have definite proof to know which is better than the other, you know, we'd want to randomly assign all patients with a complete clinical response to either watch and wait or TME. But as you can imagine, if you tell someone your tumor is gone, you want me to take out your rectum, or you want to watch, that might be a little bit hard to accrue for. You know, again, this study published, you know, median follow-up was 3 years. So again, longer term data might show us a little bit different results. Higher, you know, they had a quite high pathologic complete response and rate of organ preservation, a little bit higher than what, you know, previously was reported in the literature. And I think one of the questions that will I'd like to kind of hear from the group, as this does seem to be some kind of variability institution to institution in terms of the rates of patients who might be eligible for watch and wait. And then again, I find it interesting, patients who had a TME, 10% of them had a pathologic complete response. So, how do we better identify these? We potentially missed 10% of patients that may have been a candidate for watch and wait. And so there are still some limitations in terms of how we're identifying and, terming a complete clinical response. So in conclusion, the OPERA trial demonstrated that, they concluded organ preservation can be achieved in about half of patients with rectal cancer treated with TNT without compromising on survival. And with that, I will pause and open it up to Dr. Marroquin.
That was wonderful. Thank you, Tessie. Absolutely wonderful. True to form. I wanted to see if Dr. Hall has joined. Looks like maybe he's caught up in something. As I was saying earlier, I actually, when you travel, you get stuck places, and I've actually never watched The Masked Singer until one day I was stuck at JFK, but it was just the most entertaining thing in the world. And so, to that end, this next individual, in addition to being quite a surgeon and quite frankly, a brilliant human being, has taught me a great deal about this. And, I have to admit that even to this date, while Tessie said, we've got your tumor's gone, but part of me would think, but I've got tumor cells in there. I think biologically, immunologically, and stuff, and immune surveillance of cancer, I just want that rectum out. But this masked surgeon has really brought this to fruition locally for us. Again, I think Vermont was the third leading accrual center to this trial, and I think by no coincidence, our masked surgeon here was one of the people that drove that, and he's really taught us a great deal about this. And I'm very happy and fortunate to say that Dr. Peter Cataldo is joining us tonight to give us his perspective on his participation in the trial and how this has come to fruition here locally.
Thank you, Carlos, for the kind introduction. I'm not going to sing for anybody, thank goodness. This clearly has been the biggest change in the management of any disease for me in my entire career. And it's amazing to see how this has changed the lives of the patients that we take care of, and maybe more correctly, not change the lives of the patients we take care of. We've been fortunate to accrue many patients in the trial, and I personally have managed at least 100 patients non-operatively for rectal cancer between me and my partner. So we have a very big experience, and it's an amazing thing. The most grateful patients that I have by far are the ones who have rectal cancer and I never touched. It's an amazing thing. If you take out somebody's rectum and you do it perfectly, you change your life dramatically. If we let our radiation and medical oncology colleagues fix their rectal cancer and we stay away from them, the patients are much better off. So my principle is goal number 1, cure the cancer. Goal number 2, provide the best possible functional outcome. Goal number 3, minimize complications. And I think that Tess described this beautifully. That's what this does. And we are fortunate that we have great colleagues in medical and radiation oncology. And I think our radiation oncologists have very good aim, because our complete clinical response rate is in the neighborhood of very close to 70%. And I very rarely do a low anterior section now. Our principle also is one local therapy. So we would try hard to not do chemoradiation and surgery unless it was absolutely necessary. We shoot for one local therapy. It doesn't always happen, but that's the goal. And we found this to be a giant change in the management of people with rectal cancer. A couple of things that we learned along the way is that as great as MRIs are, they're not the gold standard for managing complete clinical response. In the ARPA trial, there was a disagreement between the MRI and endoscopic findings. Endoscopic findings trumped it every time. and they are more accurate. The other thing we learned is that you can be patient. When you finish TNT, if there's a question of a near complete response, there's no need to jump to surgery. We wait many months if there's continued improvement, and a small percentage of individuals will go from a near complete to a complete response, and they will save themselves coloanal, LAR, or APR. And it's been a pleasure to be involved with all this. I have to give a shout out to Julio Garcia Aguilar, who has been the leader in the minimally impactful management of rectal cancer, starting from increasing the time between adjuvant therapy and surgery, adding local excision to the management of rectal cancer, and now finally embracing and becoming an international leader in non-operative management. So we were lucky enough to be not only accruers in that, lucky enough to be developers of that trial, and I was lucky enough to be an author who helped write that paper. So it's been an amazing privilege to do this, and it's a giant change, and we need to embrace it. And if you go backwards a little bit, you think about anal cancer, because Carlos, you're probably old enough to remember when we operated on anal cancer. Now, if you took somebody to the operating room for an anal cancer, instead of giving them chemoradiation, you would be, branded as a crazy person. And that is what will probably happen to rectal cancer in the next 20 years. Thanks.
Thank you so much, Pete. Even without taking people to the OR with anal cancer, I'm sometimes still branded as a crazy person. But I'd like to open it up to the other participants to hear some comments and potentially some questions or ideas on how this could potentially be improved. And again, one of the things that the vision of this whole New England Surgical Society Intellectual Happy Hour is, over time, I can foresee an era when, Dr. Aulet and some of our local younger colorectal surgeons in the region potentially bring this to a higher level in terms of the work that's being done. So I'm really curious if anyone has any additional comments or questions they'd like to pose.
May I
Carlos,
ask a question?
okay, go ahead.
Oh, hi. Hey, Maria Audet. I'm at Maine Med. I'm relatively new to New England. I moved here about a year and a half ago. This is not really related to Journal Club, but, like a question about Journal Club, but technical question. So we have had a rash of patients within the last year or so who initially had a complete response, and now we are operating on them after a local recurrence up to about 2 years later. And they have been the absolutely most miserable cases I've ever done in my life. Any thoughts on surgical techniques or anything like that to help make these cases more technically easy?
Anyone?
Carlos, I would think that would be Peter or Tess.
I've not been in
Okay.
practice long enough to have the 2-year local recurrence. I'm just there, so maybe this is better for Cataldo to tackle.
They are horrible, those cases. In our experience, fortunately, they're few and far between. And I probably have done 5 of them in my career, and they're all terrible. And most of them are APRs because these individuals all have relatively low cancers. Got a couple that I've done LARs on, but I find that when you're doing an APR, you have a sea of white between the rectum and whatever's nearby, and that dissection anteriorly between the rectum and the vagina, or the rectum and the prostate, is really difficult. I do all my APRs prone, and I start from the perineal dissection, and I'm just ready for a long, difficult case. And sometimes you're operating millimeter by millimeter when you're separating the plane between the vagina and the rectum, or the urethra and the rectum in men, and it's just hard. I don't know of any special tricks in that circumstance. I think it's also difficult for the people who don't have a complete clinical response, and now it's 9 months since they had their diagnosis and their first treatment. They're just as hard. They're very difficult, and those are often bigger tumors too, so they're maybe even harder.
This is Justin Makel at University of Massachusetts. Tess, great job with that presentation, and it's great to have you representing our team. I guess, Maria, I would say that none of these operations are easy. You know, you said, how do you make it easy? They're never easy. They're the most challenging operations, particularly for these low-lying tumors. And I think that it's a great case to tackle with a colleague and, you know, not rely on the resident of the day. And I think that when you put two experienced people together, and whether that case is being done open or laparoscopic or a combination of both, I think it's one of those cases where, you know, having an experienced assistant, you know, giving you a hand can not only make the operation feasible, but, you know, potentially be the difference between, you know, an APR or sphincter preservation or not. So I don't have a great answer for you, but I don't think anybody's going to be able to tell you that these cases could be done easily. You know, it's funny that
at least your guys' responses are justifying how miserable Parker and I sometimes feel doing these cases together.
Yeah, it's funny that Peter made the comparison to squamous cell carcinoma of the anus, because, you know, I had a young patient about 5 years ago who, you know, following neoadjuvant chemoradiotherapy, I always like to reevaluate the tumor, and I did his flex sig, and there was nothing there, and it was gone. And he, you know, he turned to me and he said, "You think we can treat this like anal cancer?" And I thought to myself, man, these patients are educated, they're insightful, and they realize, like, that, you know, that shared decision making is so critical. And this guy was committed, you know, to that approach. He had, you know, learned about it, and I've been following for 5 years, and he's still, you know, cancer free, and, you know, he preserved his rectum. And I agree with Peter. This is happening. It's unfortunately, it's kind of putting us out of business, and you know, we're having less and less opportunity to teach our residents, our fellows, how to do low anterior sections, because more and more patients are getting on with, you know, rectal preservation. So I guess one question I have, Tess and Peter and whoever else wants to comment, is like the protocol for following these patients, which involves, you know, physical examination, endoscopy, and imaging, is, you know, really relies on all three. And there's a lot of debate out there about what level of tumor should qualify for watch and wait. And, you know, 4.5 centimeters, these are low tumors. Obviously, they're all within the examining finger. And there's a lot of debate of whether you should be offering this to patients with tumors of the mid to upper rectum that, you know, you might not be able to palpate. You know, I personally think that, you know, good endoscopic examination and, you know, radiologic studies are going to show you anything on the mucosal surface or anything underneath the mucosa. But it's sort of like heresy to suggest that you should do it for lesions that are higher than you can examine with your finger. I'm curious to know what people's thoughts are on that.
Well,
I guess I can comment, Justin. Hello, how are you? I don't think the digital exam is the deal breaker. I think it's a shared decision making, just like you said. And for me, the upper rectum and the lower rectum they shouldn't even have the same word. They're totally different organs. And to me, if I can do an operation and preserve good anorectal function without neoadjuvant treatment, those individuals get an anterior resection, by whatever means you need to. But if the operation is going to result in bad function for whatever reason, based on the patient's anatomy, the patient's physiology, the tumor height, then those are individuals who I consider for watch and wait. But if there's somebody who's young and thin and healthy and has a tumor at 10 centimeters, I recommend they have primary surgery with no neoadjuvant if their circumferential radial margin is not threatened. So I don't use it for upper rectal cancers unless there's some reason, like the patient's gigantic, or they have significant comorbidities, or they already have very bad anal function and they'd like to preserve their rectum in that circumstance. So that's how I feel. And I don't have a magic number, but if I feel like I can get it out and cure them and give them a good functional result, then I'm less likely to do watch and wait.
So I wanted to comment about how poor Marie got stuck with a lot of these patients. Parker here from Maine. Dr. Marroquin said, you know, take it out because he's seen the patients whose rectums look fairly normal after treatment, but sure enough, there are some islands of cells in there that the pathologist find, and you know, we've all seen that. Now with this TNT, we have more patients who have an excellent response, and the conversation I have with patients usually ends up, unless I say you have to have surgery now, it's really what we should do. They're going to take the, oh, well, then let's wait. And they're going to sometimes stretch that out even past the point where we say, okay, now you have to have surgery. And so that's how we got to a couple of patients who were a year or two out and probably waited way too long than they should have. And so that's my recommendation is just look at the results really carefully and choose your recommendations carefully also when you're talking to patients about this.
Thanks very much for that. Anybody else?
How much do you guys take? Oh, sorry, someone else can go.
No,
No,
go
that's
ahead.
okay.
Oh,
That's okay, Marie. You're in it. Go.
How much do you guys take into account a patient's age when you're counseling these patients for watch and wait versus not? Like, I know you mentioned like a young, healthy patient, upper rectal cancer, but you know, a lower cancer where you think they're going to need maybe like a coloanal. How much does their age play into a role with what you counsel them on?
Not much for me. I talked to them all relatively the same. And one of the bad parts about doing watch and wait in somebody's young is that essentially eliminates options for radiation in the pelvis for other problems. But we do have that discussion, but we've done it in people in their 30s successfully.
Yeah, I don't think I kind of give the same spiel to everybody, but again, taking into account, I mean, the elderly patients, you know, baseline function might be different than your, you know, younger patients. So thinking more about function rather than age.
Yeah, I don't really think about age too much, but I definitely think it plays into the concept that you're not done at 5 years. You know, we think about these you follow someone for 5 years and then you're off the hook. There's no way. I mean, first of all, it's like way too early in this experiment to be committing people to 5 years and saying we're done. And there's, you know, for sure, especially if you think about our patients following like local excision of rectal cancer, you're not going to want to stop their surveillance at 5 years either. I think it's critical that we continue to follow these patients for probably up to 10 years.
I'll make some comments. My training was in HPB and pancreas and upper GI work, but early in my career when I was at Boston City Hospital and University Hospital, and we did not yet have colorectal surgeons. I did a fair number of these, as I suspect Giles did as well. And here's another beautiful operation, the TME, that we're doing away with, which is a shame as far as operatively, but I agree that this is such a wonderful thing to be able to offer patients and decrease the impact on their lives. And you think about the lessons we learned from the squamous cell cancers of the anus as well as the esophagus. And you have these fixed organs where we've learned that adenocarcinomas do respond well to the same sort of therapy. So you wonder where else this might eventually be applied if we can have certain tumors fixed so that they don't wiggle around, and if there are circumstances where you won't harm adjacent tissues for similar therapy. I'll tell two stories and I'll put up in the chat a little history from the Boston Surgical Society on the Bigelow Award, but I was present, as Tess mentioned, last month when Mark Rubin presented Dr. Habergama with the Bigelow Award, and it was really impressive. Every colorectal surgeon from within any kind of distance from Boston really enjoyed being there and meeting her or seeing her again, and just having a blast with her. And what a lady and what a story. And first woman professor of surgery in all of South America. And you can imagine the grief that she took proposing this, and just a real pioneer and groundbreaker. And it was a treat to get to meet her. The other story I'll tell you related to the TME is when I was a governor of the college, I remember attending a dinner, and one of my table mates was John McFarland, who worked with Heald as the colorectal surgeons, I'm sure know. And we chatted. My wife is in business and knew nothing about him, but she said, I don't know anything about surgery, but you seem like you're very important. What have you done that's noteworthy? So it was great to listen to him explain what he had done with rectal cancer in polite company, and he was really patient and wonderful about explaining this to a non-surgeon, non-physician. So he died last month, I think November 10th, as I read, at the age of 85, and was another big pioneer in TME.
Thank you for that, Dave.
One of the things we
Giles.
should be thinking about as we move forward is that immunotherapy is coming, right? And we know that the study at Sloan Kettering with Sursic, 100% of the patients had a complete clinical response to immunotherapy alone, all MSI deficient tumors, but no radiation. So I think that as time goes on, there are a lot of new tools that we can use, and it's important that we think about them, even if it puts us out of business, because even a beautiful TME done perfectly with an anastomosis a couple centimeters from the dentate line really destroys function in the vast majority of people, no matter how well you do it. It's a beautiful operation, but not if you're the person having it. So I say, let's embrace the new therapies. And Tess, amazing job. It's nice to see you all grown up. We miss you in Vermont, and we wish you could come back.
Thanks. Yeah.
Yeah.
She can't.
Yeah. tug of war now. No. I'm in Worcester. But no, it's interesting you say that, because I do actually have 2 patients already that I am following who have had rectal cancer immunotherapy and have had a complete clinical response. I'm still trying to figure out how to watch them. They're on trials at Dana-Farber, but I've been the surgeon kind of following. And so it's interesting to see how the immunotherapy will also evolve in the coming years.
I think Justin, though, brought up some really important points, particularly, what's the length of the surveillance, and I would remind everyone, what Dr. Blake Katie said, right? Biology is king and queen, and particularly with, reference to the biology of tumors and cancers, right? And so the population of patients that brought up the greatest question to me was the patients who had the TME and had a pathologically complete response. I guess 2 questions. One, how did they end up with a TME? If they, what was the indication for the TME if in fact they were found to have a pathological complete response? But thinking outside the box, what is going to be the role of a liquid biopsy, or turning it the other way around in these patients who up front have a histologic diagnosis of cancer from a biopsy? What about, Dr. Marshall drank H. pylori and put, foregut surgeons out of business, but there's still work to be done, right? Surgeons can, recover, harvest tissue, and then subsequently, what I would say, we've got a young Dr. Rainey, young Dr. Audet, all these young people who, literally, I think the next level of things when we talk about immunotherapy, potentially the diagnostic potential is there too, in terms of sort of collaborating with an immunobiologist who can subsequently develop directed antibodies that could potentially provide a direct diagnosis. And I just wonder if anyone's familiar with that kind of work, because to me, the sweet spot is figuring out who really does end up needing surgery at the end of the day and who doesn't. And then to Justin's point, it provides a mechanism for more accurate, more sensitive follow-up, I would believe. I'm just curious, again, part of the vision of this is, to think outside the box and start to develop other collaborations throughout the New England region.
So,
I would say a couple things. Sorry, go ahead.
I was just gonna make a couple of comments as well, and I can speak a little bit to that, Carlos. I mean, certainly there are people who are now trying to use AI to design basically antibodies fundamentally to see if you can manage diagnosis. I don't know that it helps you too much in a situation like this, because we've been thinking about it at the other end of the GI tract with the neoadjuvant therapy of distal esophageal and gastroesophageal cancers, where we face a similar issue. So it's the same story. It's a very similar story, a little less worked out than it is in rectal right now. But people are, in fact, trying to. We've been trying to see if we could use liquid biopsies to tell us whether we have residual disease in the specimen. The difficulty, of course, is that even if you have a complete clinical response in these specimens, it doesn't mean you're not going to get metastatic disease distantly, which would theoretically also turn up on any sensitive assay on that. But the comments, aside from drawing attention to the other end of the GI tract, as David's probably used to thinking about as well, is that I think it's wonderful, Carlos, how this one has blossomed. Really, it's really starting to take off. And so I just want to thank you. And Tess, that was a great job. I had a similar question I was going to ask about, two about the article that you presented to us so beautifully. One was exactly the same thing. I presume that patients who got TMEs that didn't have any tumor in them just chose to have the TME, and that basically people who had a complete response were offered, but they didn't necessarily have to accept the TME. And then the question that you posed at the end of whether or not those things should have been randomized, I guess with the results we have, my response would be, so what? You got the the bottom line has been achieved at least up to 3 years, and the third point I was gonna raise was that, or comment on, was the astonishing impact of immunotherapy on some extraordinarily advanced rectal cancers in that Sloan Kettering trial. It's sort of mind-blowing. And so as people imagine how all this stuff may go forward, the biology of what it means is you can have quiescent disease in the rectum and keep it that way if your immune system is controlling it, in all probability over a long period of time, is what it's beginning to look like. And so part of the work in immunotherapy always is to try to turn tumors that are not responsive, that, for example, are mismatch repair sufficient, into ones that will in fact respond to therapy. There's an awful lot of work being done along those lines now. So I think it'll be an interesting future. I can't wait to see it. But I want to, Carlos, thank you again for putting all of this together and making it go.
My pleasure. It's all, again, it's the spirit of the society that drives this.
I think that it's difficult to identify a complete clinical response, particularly if you don't have a lot of experience. We had done a study looking at endoscopic imaging to see how accurate surgeons were. But I think the biggest problem is that the MRI is not valuable in identifying a complete clinical response, and very commonly overcalls the residual tumor. And I think a significant percentage of people end up with an operation because the MRI says they have a mixed T2 signal, possibly persistent tumor, and those individuals get a resection. We don't operate on them. And I can tell you that in my experience, I have operated on 0 patients who have had no residual cancer when I thought they had an incomplete response. The other thing that's really important is we do need to follow patients for a long time. Justin's exactly correct, but it's important to remember 80% of the recurrences happen in the first 2 years. And that's true for regrowth too, whether it's a distal recurrence or a local regrowth, it's within 2 years. Final point is, when somebody develops metastatic disease after you've done non-operative management, some people would say, oh my gosh, I screwed that person because I didn't take out their rectum. I say just the opposite. We did a local therapy to the rectum. The disease has been controlled locally. They happen to have metastatic disease, but me taking out their rectum was not going to prevent them from getting a lung metastasis. And those lung metastases right now are quite manageable. So we should not think that because somebody has developed metastatic disease after non-operative management that we failed them. That's the wrong paradigm.
So I'm just going to jump in because I totally agree, Peter, that is, you know, we face the same thing when we do another toxic operation, and we can't tell whether or not there's been a complete pathologic response based on the imaging and the endoscopic ultrasounds and the biopsies and so forth. But you're absolutely right. I mean, you know, metastatic disease turning up later is not something later. It's something that already happened that you're just discovering later. And so if you've got a clean rectum and distant metastatic disease, you still can have the distant metastatic disease. And you know, I totally agree with the point you're making. But hey, Tess, I have two other questions I thought of. Was there any subset analysis of node positive patients in there? That would be one question. And then secondly, what is the salvage rate? If you can do the APRs or difficult low anterior resections, but is there any data on how that turns out? And I would say it seems to me it would be perfectly fine to call upon a friend here at this banquet.
Yeah, so a few things. In terms of the first question you asked earlier, the 10% who had the complete clinical response in the pathology specimens, I think those were deemed as, you know, needing surgery, but then ultimately the pathology showed the complete response. So as Dr. Cataldo mentioned, it's just we could have done a better job of identifying those as complete clinical responders preoperatively, and whether that's surgeon experience or the imaging or what. And then in terms of the other two questions, they did look at salvage rates. I can't think of the number off the top of my head. I was just trying to pull up. I think they did present data in terms of the regrowth, and did not see any difference in overall survival or, you know, in terms of salvage, same survival, and I think slightly higher rate of APR, if I'm recalling correctly, in terms of maybe less sphincter salvage for those salvage surgeries. And then I do not believe any subset analysis in terms of nodes, but Cataldo, you can correct me if I'm wrong.
So if you had to have surgery for recurrent local disease without distant metastatic disease, that your chances of surviving, marking it from the beginning of the study, is the same as if you had gone straight ahead to the surgery originally. Is that a correct interpretation of that?
That is correct. That's my interpretation.
I agree, Tess. Yeah, that's for sure. And
yeah, and I would say that's the overall feeling from, you know, most of the trials that have been done to date.
Yeah, and regrowth rate is about 15 to 20% in the trials throughout the world, so it's a relatively small number. I also think that you find out when you do this that some people the tumor just disappears right away, and other people you're sort of on the fence, and those individuals who you're on the fence are much more likely to have incomplete response or local regrowth. And you can gestalt that after you've seen a lot of people who have had TNT. And organ preservation is higher if we do chemoradiation first, followed by consolidation chemotherapy. That's one of the big points of the trial. So now that the trial's finished, when we treat patients with non-operative management, unless there's some other reason, we do chemoradiation first, followed by chemotherapy. We're also part of the non-MERA trial from St. Louis, which is short course. And we have accrued a large number of patients in that trial my experience with that is that the patients have significantly higher rates of proctitis. And even though their radiation is in a short period, it's much more difficult for them to get through. And it's also harder to find the persistent tumor in the sea of proctitis.
Is there anyone like, what patient would you do induction chemo first?
Somebody who we try to avoid that at all, unless somebody has evidence of a metastatic equivalent. Let's say they might have a big para-aortic node,
Yeah.
And they have a small rectal tumor that's completely asymptomatic. Those
Right.
individuals might start with induction chemotherapy, but that's very unusual.
Yeah.
For us.
I would just say one other quick thing is that I really don't feel like all rectal cancer patients, locally advanced rectal cancer patients, should be treated with TNT. I know that it's like the new approach and it's the hot subject, but I don't think that all patients can make it through a 6+ month period of time of treatment if they're like near obstructing, or sometimes patients come in with like a little localized perforation, and the medical and radiation oncologists want to put people on TNT. And you can run into problems during that TNT where they're getting chemo for 6 months, or the tumor doesn't respond appropriately and they go on to develop an obstruction. So I still think that there's a role for shorter time period neoadjuvant chemoradiotherapy, as opposed to just putting every patient on TNT hoping for that complete clinical response.
So, you bring up a good point, right? And so one thing that sort of is always sort of, we sit at M&Ms and or have discussions with residents about patients they're seeing. And so how do people feel about this new age where, we're using stents more liberally, to allow patients to get bridged to potentially at least radiotherapy and some form of TNT that we know potentially will optimize their outcome. And I do have to say, I hope that there's going to be a follow-up article on this trial with a longer period follow-up. But there are new tools and new arrows in our quiver, and I think stents are becoming some of them.
Yeah, and Justin, while you're thinking of answering that, what do you think about the notion of doing a temporary colostomy so that they can finish their TNT, right, without constantly bathing the area in stool, so to speak, or the perforation? And I don't know, what does Peter think about that too? Tess, what do you think about
absolutely. I think there's definitely a role for upfront diversion, and that diversion doesn't have to result in a permanent colostomy. But we've had a fair number of patients who present with the scenario that I described, with either a near obstruction or a fistula to the bladder, or a little localized perforation, where we will divert them up front and then get on to the neoadjuvant treatment. That could be as much as TNT versus just neoadjuvant chemoradiotherapy. I'm not sure that stenting is the best option for these rectal tumors, particularly the mid to low rectal tumors, because of the discomfort it creates in the tenesmus and the potential for migration as well. So I think and it also causes a pretty significant inflammatory reaction around it. So we tend to avoid the stenting for the lower rectal lesions. But I agree with you. It's a great option, particularly for those more proximal colon lesions. So hopefully be able to get by with a single stage resection and avoiding a stoma.
I would agree too. I think that sometimes patients present with a bowel obstruction, and the first thing you have to manage is bowel obstruction, not cancer. That's the acute problem, and you fix that whatever way is appropriate. And I think that for a distal rectal cancer, a diverting stoma fixes their bowel obstruction. Then you can manage their cancer later. But a stent, I agree with Justin. And UMass is the stent king, is the stent kingdom of New England. So if Justin is telling you that, he really knows much more than we do. But I think the role of stents in the rectum is very minimal. We use diversion instead of a stent to fix the bowel obstruction, and then we do whatever we need to treat the cancer.
Wonderful. Anybody else?
If Catherine Bornez is still there, Catherine, you should speak on this. You were debating it the other day. We've got one of our senior residents who's interested in colorectal surgeries is on.
Can everybody hear me? Sorry, I'm still at the hospital and don't have a camera.
We hear you well.
Well, hi, I'm Kathy Boharney. I did debate on this topic just yesterday. Thankfully won my debate. I'm just really happy to be here and hear everybody's thoughts on this. I do think the future is kind of changing for rectal cancer surgery, being that I will be a colorectal cancer someday, colorectal surgeon someday. I will have to deal with these issues. So it was really great to hear all of your perspectives on the new evidence that is out there on the topic. But thank you, Dr. Whalen, for the little shout out there.
That's wonderful. So again, I'd like to thank our master surgeon and Tessie for her very eloquent presentation. This again is entirely driven by the spirit of the New England Surgical Society, and I thank you all for taking the time, from your family on a Thursday night to participate in this. Again, I think the fact that our trainees, Catherine, is on to glean some perspective are some of the reasons we do this. And hopefully, as we continue to move this down the road, it will generate a regional collaboration that will be second to none. I hope you all have a wonderful holiday season and wish you the very best in the new year.
Thanks,
very much.
everybody.
Thank you, Carlos. Enjoyable and educational. Couldn't be better.
Yeah, thank you.
Everybody on the line, tell your friends.
Thank you, everyone.
Great job, Tess.
That was great, Tess.
Yeah, thanks, Tess.
Thank you. Thank
You did it way better than Jason. Way better.